Hey guys, welcome back in. So this evening, I'm going to begin prepping you for your National Registry Airway section. Now, by no means is this, I don't want you to consider this as a comprehensive guide. There's so much information out there and so many factors to take in. On the National Registry website, it does actually say that no one source can prepare you for National Registry. There are several places you can look for, certain things will be in there, like the National EMS Scope of Practice and the National EMS Training Guidelines or Educational Guidelines. Those are two links I can provide you. They're both gigantic PDFs, but they would guarantee and verify that all the right information and stuff that you need to have is with you. The best thing you can do is have a strong knowledge base of everything in those sections and every adjunct and device you can use, and always choose to do what is best for your patient. This is not a crazy hard, super duper EMT test, guys. This is a very basic, just competency exam. I don't really believe that you can actually measure competency with the National Registry test, but it is the best thing we got right now. It is the certification exam, just to see, do you have the mental knowledge to work through strategically created problems to prove that you're not going to hurt anybody. My goal as your EMS instructor, and Mr. Larry's goal, and the National Registry's goal, is just to put good, strong, solid providers out there. This is the only way we can do that, is by testing you in a high stress scenario or high stress written exam, because at this point, all the marbles are on the table. So let's begin. I'll go ahead and share my screen. So, all right, respiratory section. The respiratory section, let's talk about it. So some respiratory terms that you're going to need to nail down and to really grab hold of are going to be ones like ventilation, which is simply the movement of air in and out of the body. Ventilation is simply moving the air in and out of the body. Okay. With the lungs. Diffusion, that is the process of gas exchange that occurs between the pulmonary capillary bed and the alveoli, moving these particles from an area of higher concentration to a lower concentration, and it works through what's called net filtration. We breathe out carbon dioxide, we bring in the oxygen. So crackles are going to be fine bubbling sounds heard on auscultation of the lungs. Fine bubbling sound. Sounds like secretions in the alveoli. Rhonchi, coarse lung rattles caused by secretions in the lower airway. Stridor is going to be that high-pitched whistling or crowing sound in the upper airway, and with wheezing being a high-pitched, coarse whistling sound when you breathe. That is definitely a lower airway sound. Oxygenation, the actual act of placing O2 molecules on hemoglobin. There is a difference in ventilation and oxygenation. There is a huge difference in oxygenation and ventilation. So do not get the two confused. If you've got a patient that needs oxygenation, that does not mean you need them to be bagged. When I'm talking ventilation, I'm talking BVMing somebody, breathing for them. Oxygenation is just putting a possible small airway adjunct on, like a nasal cannula or a non-rebreather mask or something of that nature. Big difference in the two. Now, when we're talking about cellular respiration, that's when O2, glucose, and water enter a cell, glycolysis ensues, and production of adenosine triphosphate occurs, and that, of course, be your energy creation. So with more physiology, we've got hypoxemia. Hypo being the prefix word, meaning it'll change the direction, the function, or give the word intensity. Oxemia, of course, will be a root word and a suffix. We've got to break these medical terms down. I think I told you guys in the first lecture PowerPoint about registry prep that your medical terminology has to be solid. Registry is not going to say the patient's having difficulty breathing. They're going to say dyspnea. They're not going to say kneecap. They're going to say patella. We need to nail down these medical terms and make that a very strong area of concentration for us. Students come to me from other programs, and I sit them down, and they've been having trouble passing registry, and they start to try and blame their program. And you know what? Not all these programs are to blame, because sometimes I personally know the instructors and I know they're jam up. I know they are solid paramedics and EMTs, and I know that they are very well versed educators. They believe in evidence-based medicine protocols, and I know that they're effective educators. There's a whole different skill set to being a good paramedic and being a good educator. It's a whole different skill set, especially one doing a hybrid or flipped classroom like we've done through the course of your EMT course here. It's challenging. It takes a whole new skill set. So I don't want anybody blaming their instructor. Now, sometimes you do get a really terrible instructor. That can happen, you know, but for the most part, what I've seen is not an instructor problem. It is a reading comprehension problem on the part of the student. It is an anxiety problem, a lack of testing strategies, and weak, very weak medical terminology. Without understanding what the question's actually asking you, you will not be able to answer it properly. So I've noticed that it's mainly medical terminology. So let's break it down. Come on, pen light. There we go. Boom. So the first term we're going to use and talk about is hypo. That's my prefix. Look at here. Hypo means decreased and low, right? Decrease. That's an arrow if you don't know it. Let me go ahead and erase that. That's pretty terrible. Y'all quit judging me. You're going to hell for judging or something like that. Oop. Arrow. So hypo is a prefix indicating that it's decreased, not enough, low. Ox, OX, indicates what? Oxygen. And emia means in the blood. So what this thing is translated to literally is low oxygen in the blood. That's all it is. That's all medical terminology is. It all has Greek or Latin origins, and they all basically translate into, like this one says, low oxygen in the blood. Let's take hydrocephalus. All right, hydro meaning water, cephalus meaning head, right? So it really just means water head. That's all it is. Breaking these terms down so you can understand them. I've taken the National Registry. You have two options when you become a paramedic or an EMT. To keep your National Registry license, you can either challenge the exam or you can just submit hours. Now, I do the proper hours, but I like to challenge the exam because I, as a paramedic instructor, like to look at the thing from time to time and see what it's doing, what it looks like, what kind of questions, what kind of format it's asking. Sometimes I don't want to say I throw the game, but I operate on a level that's beneath myself. I'm still going to work hard so I can pass and keep my National Registry, but I definitely want to take a look at this thing because there's no really good training software out there. There's a couple of prep programs that are not bad, and I will go ahead and give them a shout out. Like Master Your Medics, I've spoken with him and his assistants, and I've watched what they've done for a while now. They've got a really good program. They really do try to help you out, but there's no computer adaptive software out there that really can mimic what Registry is doing very well. I really like medic tests. They've some people don't like them, but my students that just took their paramedic National Registry and are walking around paramedics right now, we finished our program. We looked at medic tests and EMT.national training. I had groups do both. I really push you guys to think about these. And I'm not saying I don't know the people that run these things, but this is free advertisement. If I can help my brother who is in EMS and he's trying to make his money and trying to do a good service for us in the education industry, why would I not? If I can achieve operational goals and accommodate people, why wouldn't I? I don't know who runs medic tests. I don't know who runs EMT.national training. I just know that I put students through their National Registry simulators and through their test preps, and that it really does seem to help. They got about the closest thing I've seen. There's probably some other good ones out there, but hey, this is what I know. So hypoxia, of course, is decreased oxygen content at the tissue level, but hypoxemia is low blood oxygen level. So the ventilation perfusion ratio, we're talking about measurements used to assess the efficiency and adequacy of the matching variables. So blood flow to the lungs and being able to ventilate yourself, or blood or air coming in and out. So alveolar ventilation means I can breathe in and out and my gas is exchanged and there's not a problem. Perfusion or pulmonary perfusion is, of course, we're talking about blood flow to the lungs. Naming some issues that come with that would be what? A ventilation issue would be, let's say, flash pulmonary edema. Pulmonary edema, pulmonary, which would be lungs, edema meaning fluid, right? So we got fluid built up in the lungs. You cannot adequately perform that gas exchange through water or fluid or blood or whatever kind of liquids down there. So that would create a ventilation perfusion or a VQ mismatch that we would run into. Now, take the other side of that. That's a ventilation issue, but the lungs are getting plenty of blood flow. That's why the mismatch is there. Next, we would look at what? Let's say a PE. So I can breathe in and out really well, but there's no really, the blood flow to my lungs is actually impaired now. So that controls and deals with a lot of that. All right, what about the respiratory centers? The respiratory centers. So the actual respiratory centers of the body, the lungs are not actually the organ of respiration. They don't control respiration. Now, of course, they are the organs that are responsible for gas exchange and tidal volume and things like that. But the brain is actually responsible for air in and out. So chemo receptors located in the medulla oblongata. I've been waiting to say that since I watched The Waterboy in '98. I just love saying it. Medulla oblongata. Anyway, so these things are pretty much sensors in the body, kind of like your O2 sensor in your car. When certain levels get to a certain place, your body is stimulated to breathe. So your medulla oblongata and the chemoreceptors are reading these changes in carbon dioxide and the pH of your body. When your carbon dioxide rises, it is acidic, so it drives your pH down, making you more acidic. So your body is stimulated to breathe and blow off carbon dioxide and raise your pH to a normal level. This is all done to maintain homeostasis, that balance, like that work-life balance most of us have gotten figured out, right? I'm still working on mine. It's hard. So oxygen saturation, we're looking at 94 to 99% being target. And your SpO2 is a measurement of hemoglobin that is saturated with oxygen or carbon monoxide. Why is that important to note, or carbon monoxide? Because if a patient's been in a house fire, let's talk about this. The pulse ox that you're putting on their finger is just reading that something is attached to those hemoglobin molecules, right? When somebody breathes in a lot of carbon monoxide, which is, off-gassing of anything that burns, really, what it does is actually it has a 200 times stronger affinity for that hemoglobin. That means it will go in there and slap that hemoglobin around and knock the oxygen off of it and jump on and take the ride. Your pulse ox cannot tell the difference. There are actually pulse oxes that are specialized pulse oxes that can read carbon monoxide levels, but you need to make sure your company's got one. I actually very, very firmly believe that every fire company should have one. The fire service I work for doesn't have them. They will remain nameless. I will not out them. However, dang, bro. So hydrogen levels in the body, pH of the body needs to stay between 7.35 to 7.45. Carbon dioxide levels need to run 35 to 45. If it is greater than 45, the body begins to blow off CO2 to bring the CO2 and pH back to normal levels. That's a form of, the compensatory mechanisms of the respiratory system. And then, of course, your hypoxic drive is the exact opposite of your normal control of respiration. These COPD patients are the main culprits here. So what happens is these patients have burned out their normal chemoreceptors, probably due to the CO2 retention that they chronically have. So we talked earlier about carbon dioxide levels having to rise to stimulate breathing. It has to get to a certain amount of acidity and a certain amount of carbon dioxide levels. Those chemoreceptors are outskipped. So now these COPDers actually breathe off of low oxygen levels, hypoxic drive. So when that means when their oxygen levels sink to a certain level, they take a breath. They could actually be normally walking around at 91, 92%, and that's their normal. That is their non-emergent routine basis right there. So oxygen in the blood, we got two forms that it'll take. It'll be either physically dissolved in hemoglobin or chemically bound to the hemoglobin. The ones chemically bound to the hemoglobin, which is 98% of oxygen, is actually the one we think of when we think of oxygen in the body, but that deoxyhemoglobin is the one that's just dissolved in the plasma of the blood. The whole point of the respiratory system is to do what? get oxygen to the tissues, get rid of CO2, and help the body control the pH. That's it. Also, the composition of air and the ambient air around us is what? 20.84% is oxygen and 78.62% is carbon dioxide. So a lot of people just go ahead and round up and say 21% of the air is oxygen. And that's what a lot of fire services do. They're just like, no, that's 21%. And that's okay. I'm okay with that. So what about opening the airway? Head tilt, chin left. We use that when no trauma is suspected. This is very important for you to understand in regards to your national registry, because as an EMTB, the level of skills that you can perform are minimal. But I can tell you what, guys, the basics are really what saves lives. Let's take CPR, for instance. I mean, as a paramedic, you can do some pretty cool things, give a bunch of cool drugs, but if CPR ain't perfect, you ain't getting nobody back. There is no ROSC, or return of spontaneous circulation. So the first step, of course, during that primary assessment is that we do a what? Head tilt, chin lift. We got to get that tongue out of the way to make sure that it's not an airway obstruction. The tongue is the most common airway obstruction. Now, what if there is known trauma, or if the patient's unresponsive? Consider it traumatic. If there is known trauma, use a modified jaw thrust. If you pull up or get a scenario and the patient is just unresponsive, assume it's trauma. How did they get on the ground? Do you think they laid on the ground nicely and just took a nap, or did they like suddenly pass out and fall on the ground? It very well could be trauma. So if you don't know, use the jaw thrust. Upper airway anatomy, let's talk about it. We've got plenty of little things here to look at. So again, the respiratory center is in the brainstem, specifically medulla oblongata. That is who's going to control respirations. Upper airway, we've got the soft palate, oropharynx being the mouth, nasopharynx being up here in the nose. The turbinates and the concha are located in your nasopharynx. Their job is to warm and humidify the air you do bring in. And this picture down here we're looking at is a open and closed glottis. As a paramedic, when you're learning how to do airway maneuvers, you're in EMT school, but your paramedic will learn this, and you need to know it too. This is what we're looking for right here. This section of open airway is what a paramedic will actually put an endotracheal tube down right there. But one of the landmarks we use is these white bands right here, those vocal cords. This is what happens when the glottic opening closes. And this big leaf-shaped flap right here is actually epiglottis. Now, its job is to cover the trachea while you're eating, so you don't, swallow water or food. Even the best of us, myself included, has choked on water from time to time accidentally. It has happened. It will happen. And sometimes they malfunction. I can't give you the premise of why, when, or whatever. Let me erase my junk here, and we'll keep on keeping on, man. So your job in EMS, establishing and maintaining a patent airway and ensuring effective oxygenation and ventilation. That is vital to patient care. That is vital for patient care. The human body needs a constant supply of oxygen. Respiratory system can bring it in and then eliminate carbon dioxide. Vital organs will not function if they are interrupted. They cannot go without blood flow. They cannot go without oxygen. Failure to maintain an airway is a major cause of preventable death in the pre-hospital setting. Even at the EMT level, you can recognize an airway issue and do something about it. What if you're way out in the middle of nowhere and you're 50 minutes from the hospital, but only 10 minutes from a paramedic? Paramedic intercept. Then get the paramedic there to take over the airway. That is what's best for the patient. Or if you live out in, Redneckville, Georgia, or where like I'm from originally, you need to be thinking about flying that patient, getting them to a hospital as soon as possible. So you need to understand the importance of early detection of airway problems, rapid and effective intervention, and continual reassessment. So you can recognize the same problems that a paramedic can, even at your level, EMTBs. And rapid and effective intervention. Patients don't die of hypoxia, and they don't have brain damage from cells dying because of lack of oxygen, because you don't intubate. You as an EMTB cannot intubate. But what you can do is ventilate. They will suffer brain damage and hypoxia because you do not ventilate. Patients do not suddenly deteriorate. EMTs, paramedics, nurses, doctors suddenly notice. Pay attention to your patients. Don't be in the back of that truck Snapchatting your boo. While you at work, be all at work. And here's another thing. When you at home, don't answer your phone and don't be picking up all this crazy overtime. Be all the way at home. Myself personally, I was eating dinner a few minutes ago. My phone goes off. It's one of my students from the paramedic class at the fire department. And I was looking over there, I was about to get up from eating my delicious steak dinner. And my wife's like, it's after 5. And she's right. My wife had to check me because guess what? I have to have a work-life balance too. I have to have a work-life balance too. This is important for you to know. I don't know why I'm going off on a tangent here, but I just want to make sure you guys are aware of it. Don't work yourself to death. Please don't. Don't be like me or used to be. So proper airway maintenance begins at the basic level. You can take it all the way up to paramedicing and intubating and needle cric in the throat and all this other mess. But all interventions must begin with good positioning, hyperoxygenation. The best airway interventions will be fruitless unless you've got effective basic airway control and supplemental O2 delivery. One of the most important things you can get is a good, strong seal with that big CE you got on there. Good CE seal, and then bag the patient. Now, of course, problem with bagging the patient is that some of that area is going to the stomach. Eventually, there might be a emesis issue where they vomit, or the air in the stomach and the juices and all that come up. So, yeah, that's an eventual thing to worry about. But I would definitely have suction ready and be ready to deal with that if it happened. Because again, you as an EMTB cannot do any kind of supraglottic airways, or you can't do any kind of endotracheal intubation, but you can call people that can, or transport them to people that can. So the trachea is the conduit for air entry into the lungs. The trachea is one pipe. If that bad boy gets clogged, what's the problem? Well, it means no air is getting past it to the lungs to oxygenate it. That thing needs to be unclogged. So a reminder from your CPR class, guys, for the conscious choking patient, we got Heimlich maneuvers just above the umbilicus, form a fist, put your hand over it, upward thrusting motions to increase that intra-abdominal pressure to help hopefully increase the intrathoracic pressure to pop that bad boy out of there. That is what you do for a conscious choking patient. What about the unconscious choking patient? When a patient becomes unresponsive, you are to do CPR. Now, if you're doing the Heimlich and they go unresponsive on you, lay them gently on the floor, lean their head back, and then begin CPR. Hopefully the same premise is there. As you're pushing on the chest, that pressure is pushing air from the lower airways to hopefully pop that bad boy out. So every about 2 or 3 minutes, you need to be checking down there to do for what? Look, see if that thing's popped out. So trachea descends down the midline of the neck and chest to about the 5th or 6th thoracic vertebrae. The 5th or 6th thoracic vertebrae. Esophagus lies posterior to the trachea. What does that mean? So posterior means it lies behind the trachea. It is on the back side. So the trachea is up here in the front. The esophagus is in the back. And don't forget about that phrenic nerve. Don't forget about that phrenic nerve. Where's the phrenic nerve? C3 through C5 keeps you alive. What does that mean? C3 through 5 keeps you alive. So what that means, my fellow EMTs and paramedics, or soon-to-be's, is that your phrenic nerve is located on your cervical spine, the back of your neck. And an injury to that area, or spinal injury to that area, could innervate or could de-innervate that phrenic nerve. Its job is to innervate the diaphragm. So what happens is if that thing's cut loose, the signals sent by your nervous system through that phrenic nerve to cause the diaphragm to be able to, work is cut off. Your diaphragm is a muscular hollow, muscular dome-shaped organ in the lower part of your chest underneath your lungs. It makes chest expansion possible. That thing's power supply is cut off. You won't have any control over it, and the patient will have some airway issues after that. So make sure that we're remembering that about airway as well. Make sure we got that knocked down, locked down. There we go. All right, the lungs consist of smaller bronchi, bronchioles, and alveoli. So let's talk about it. So This whole respiratory tree, and that's what I've always called it, is the respiratory tree. Move this out of the way. So we got the tree branch here, the tree trunk. That'll be, of course, your trachea. The big tree branches are going to be your who? That's your bronchi. And these little tree branches over here, that's going to be your bronchioles, okay? And these little grapes-looking sacs down here at the bottom, that's your alveoli. So just think of it like a big old tree. Let's do it again. That way it's clear for everybody. So the trachea, big conduit for bringing air in. That bad boy is what? That is the big tree trunk, branches off to the bigger trees branches, and then goes to smaller tree branches, which are the bronchioles. So trachea, bronchi, excuse me, and bronchioles. Tree trunk, big branch, little branch, which is bronchioles, and then the alveoli at the very bottom, that's the little grape-looking things. That is where gas exchange occurs. So the rest of them are just pipes to bring it in. The alveoli and the capillary bed where actually gas exchange happens. So remember that your lungs and your alveoli are lined with a phospholipid compound called surfactant, not usually produced in the lungs until the newborn's about, well, not newborn, but a fetus is about 30 weeks old. After that, it might be some airway issues if you have a preemie. All right, there's your closer look at the trachea. 15 to 20 C-shaped cartilaginous rings. They're not bone per se, they're cartilage. And they're C-shaped. So they're got a little C to them. So that's the front there. Behind them is just pretty much smooth muscle. About 0.6 inches wide, 3.5 to 6 inches long, lined with cilia and goblet cells. Now, what are cilia? Now, let's take a look at this picture over here. These little hair-like things, these are cilia. And goblet cells, or as I call them, goblin cells, they're responsible for producing mucus. So debris or outside foreign bodies or foreign debris comes into your airway. Your goblet cells create mucus to trap this stuff, and your cilia are responsible for helping you hack it up. All right, so the diaphragm, here's a picture of it right here, this hollow dome-shaped little nerve musculature right here. Diaphragm contracts, moves down for inhalation. Diaphragm relaxes, moves up for exhalation. And there's your phrenic nerve stuff right there. So some lung sounds, just some quick little things about it. We got wheezes coming from the lower airway. It's high-pitched, it's musical. It sounds like you're blowing through a flute almost. That's air moving through narrowed airways. That's your bronchioles that are closing up. So that's usually done by asthma exacerbations. It can be heard in some COPD, but it's usually bronchoconstriction causing that. Crackles sounds like fine hair moving through fingers, or coarse Velcro. That is collapsed small airways and alveoli popping open. So usually it's caused by pulmonary edema. It'll sound like wet lungs really there. Pleural friction rub sounds like dry rubbing or squeaking. It's due to inflamed lung pleural, usually caused by autoimmune disorders. Then we got rhonchi, low-pitched rumbling or gurgling. That's from narrow airways, usually in the trachea and bronchi. It could be from chronic bronchitis going on there. I will tell you this, if somebody's going to buy you a graduation gift for finishing the EMT course, good Lord, I've said this before, but don't let nobody buy you no Raptors. Don't let anybody buy you any Raptors. Go and make sure they buy you a good, strong stethoscope, a good stethoscope. I'm talking about, I want you to be able to hear a cricket fart from 3 miles away. That's how good a stethoscope it needs to be. Because I can tell you, working in Atlanta like I have, on side of 75, you got a bad wreck patient with possibly a popped lung, you're going to want a good stethoscope because all them cars going by, all this noise, the sound of a big city, you ain't going to hear jack and crap. And jack left-handed. All right, so respiratory patterns. So I say this with a grain of salt. Another thing, Registry wants you to know is about respiratory patterns and those associated with, let's say, increase in the cranial pressure or lesions on the brain. but I can tell you for real, in real life, it's really hard to see respiratory patterns. It's challenging, I'll say that. You can always tell if it's irregular, but it's hard to really pinpoint exactly which one of these is going on. That don't mean it's not useful information. Maybe you'd be better at it than I was. I'm just telling you from my experience, it's easier to see that it's irregular, but it's sometimes not easy to see which one it actually is to give it a name. So me personally, when I gave a report to doctors in ERs, I'll say he's got irregular respirations. I don't want to, make myself look stupid by saying change Stokes or Biot's or Apneustic and, just not be sure. Now, Kussmaul's, that one's an easy one to recognize. So let's go through. Eupnea, that is normal respirations. Tachypnea, that is fast respirations, over 20 breaths per minute for an adult. What about bradypnea? That is decreased slow respirations. What about apnea? Apnea, that is no respirations. They're not breathing. A means without. Nea means breathing. No breathing. Bad juju. Breathe for them. BBM. All day. Boom, brother. Going back to bradypnea, if they have slow respirations, let's say less than 8, I'd say less than 10 actually, but be thinking about bagging them if they'll allow it. If they're talking to you and they just breathe slow, that's one thing, but make sure you're looking for registry buzzwords like shallow. Shallow respirations is always supposed to trigger you to be like, oh, I'm gonna bag them, just like pale, cool, clammy should trigger you to think shock like that. That's what registry wants. That's what I want. If you see that in the field, shallow respirations, I want you to jump all over it and be thinking about bagging that patient. Sound good? Yeah, buddy. Now, change Stokes is abnormal with regular periodic breathing with intervals of apnea. It's got the crescendo decrescendo pattern of respirations. I've seen this on a couple of registries I've taken. It's definitely in there. And they usually associate it with like a Cushing's response, like a head injury, an increase in the cranial pressure. So this is something I want you to look out for and make sure that you know and understand. So that's your change Stokes going on there. Biot's is abnormal, characterized by regular deep respirations, followed by irregular periods of apnea. Again, this one's going to be associated with possible head injury, possible increase in the cranial pressure. All right, so then we got apneustic, A, meaning without, pneustic, abnormal, rapid respirations associated with deep gasping. Most of the time, it's going to be stroke or trauma that caused this. It throws off that whole breathing thing we got going on. Then, of course, we got at the bottom Kussmaul respirations, which are very rapid, very deep, and that is usually associated with diabetic ketoacidosis. And it's usually as a compensatory mechanism in an attempt to regulate the body's metabolic acidosis. So this Kussmaul is associated with DKA. DKA. All right, airway adjuncts and devices. We got the OPA, the NPA, the nasal cannula, the nebulizer, the non-rebreather mask. One of the things you need to know about your national registry is which gun to shoot off in which situation. So the OPA used on patients without gag reflex. If they have a gag reflex, then we don't use it. You don't want to gag a patient and braiding them down. You don't want to gag a patient and braiding them down. If you gag someone, that's going to stimulate their vagus nerve, and that will cause them to brady down, bring their heart rate down, release acetylcholine, and that's not a good thing. It's not what we want in this situation at all. So use the OPA to move the tongue forward as it curves to the back of the pharynx. You can measure it from the center of the mouth to the angle of the jaw. Center of the mouth to the angle of the jaw. Okay, I teach differently than this thing says. I borrowed this slide. Somebody sent it to me, so I'm just using it. But we teach from the corner of the mouth to the angle of the jaw here. So keep that in mind. So insert the device along the roof of the mouth, rotate it 180 degrees anatomically. Just make sure that you know when and where to pull that thing out and use it. OPA is very important to use for these patients. Keep the tongue out of the way. And that's for patients without a gag reflex. Remember, we're going to be measuring from the corner of the lips to the end of the jaw there. Now, nasopharynx is for patients with an intact gag reflex. That means if you find that they have a gag reflex, then do not put a LPA in there. You've got an NPA. So moves the tongue and soft tissue forward to provide a channel for air, measure from the patient's nostril to the tip of the earlobe. Okay, that's exactly what we teach. Bevel always goes toward the nasal septum. The bevel is that little Sliced looking thing right there. Make sure that always curves towards the septum. All right, nasal cannula, a very mild type of intervention here. We've got the nasal cannula. It can run between 1 and 6 liters a minute. Not getting a whole lot of juice out of this thing, but that's for these smaller problems that we run into. So it can increase oxygen concentration for a patient between 24 to 44%. So the increased oxygen content that they're getting from 24 to 44%. Remember, 21% or 20.84 is what's in the ambient air around us. This is just increasing the concentration of oxygen they're getting. This is not ventilation. This is oxygenation. Of course, then you have the nebulizer, where you nebulize albuterol, ipratropium bromide or Atrovent, and sometimes maybe racemic epinephrine. This thing can hold 4 to 6, well, what's it saying, liters per minute? So it can hold a volume of, it depends on the size of your nebulizer too. I've seen bigger ones, but I'd say 3 to 6, or maybe even larger for larger ones, mLs of fluid. And that fluid would be, of course, your albuterol, ipratropium, or your epinephrine. And I've only seen it nebulize the material at 8 or greater. At 8 liters per minute, that's when the nebulizer of the liquid turns it into a gas. So when we put our fluids in there, or the medication in there, we're going to nebulize. I've only seen it really start working to nebulize at about 8. 8 to 10 is kind of my magic number I like to have it at. Now, if you go much further than that, go to 12 or 15 liters per minute, it's hard to keep the O2 tubing on the tank. It just pop right off sometimes. Next, you got the non-rebreather mask that goes between 12 and 15 liters a minute, and the oxygen concentration can be increased to 80 to 100%. The BVM. Now, this itself is what I'm talking about when I say that we're going to ventilate a patient. This is ventilation, moving air in and out. We've got expiratory valve at the top. There's your face mask. If you ain't got a seal, you ain't got nothing. You ain't got a seal, you ain't got nothing. You got a PEEP valve right there. Your pop-off valve is looking right here. Self-inflating bag, air inlet, one-way reservoir, and O2 reservoir, air inlet pressure release valves, O2 tubing, and the reservoir bag. All there, baby. So when you're bagging a patient, at least have 15 liters per minute of oxygen flowing through the bag. If you're not bagging them with oxygen attached, you're only giving them 21% oxygen. If it is an oxygenation problem, you're only going to give them 20% oxygen, 21% oxygen. So make sure your O2 is hooked up to the BVM. So deliver 1 breath over 1 second of time. That means you're squeezing 1001. Squeeze the bag until you have chest rise. Do not squeeze it so you can pop their lung. This happens a lot, especially with overzealous rookies that are running their first arrest. You as the senior man on scene, EMT, paramedic, school guy, you need to be directing traffic and watching these guys that they're not going to overinflate the chest. We only want chest rise. Anything more could be barotrauma. So just because this thing can deliver 1,600 mLs of air, the average adult patient only breathes a tidal volume of 5 to 700, with 500 being the most normal you'll find. So the bag will hold 1,000 or 1,600 mLs, but that don't mean that's what you're giving. You're looking to give 1 breath every 6 seconds or 12 breaths per minute in adults. Some specific respiratory emergencies that we're going to run into and that you can treat and work with them as the EMTP. Let's talk about it. You've got COPD, asthma, CHF or congestive heart failure, pneumonia, pulmonary embolism, and pneumothorax. Let's talk about it. So COPD is an umbrella term that covers both chronic bronchitis and emphysema. So that's your blue bloater and your pink puffer. So the chronic bronchitis is usually overweight. They have a very productive cough with tons of sputum. They have chronic bronchitis. So their bronchioles and bronchi are chronically inflamed, and they chronically are full of mucus. They're always coughing up sputum. A lot of these smokers get this. Coarse bronchi, chronically cyanotic, mild to chronic dyspnea. They could have a COPD exacerbation, meaning they're going to have some serious problems, and they're going to have that bronchoconstriction, trouble getting air in. They're going to have wheezing. They're going to need O2, possibly some albuterol. Now, do what your local protocol states. The EMTB can assist with a metered dose inhaler. A metered dose inhaler, which is, of course, that thing that that kid off the Sandlot had, you know, that little inhaler after he kissed Wendy Peppercorn. Wendy Peppercorn. So that's that breathe for you thing. You can assist with that. Depending on your protocol and where you're at, you can actually give some albuterol in certain areas, depending on if your medical director signed off on it. Remember, you got to have authorization, training. Now, my class, you guys, I've trained you to give albuterol and to put together a neb. However, you have to have authorization to perform this from your medical director. So albuterol 2.5 and 3 mLs, and you can get that thing done. Blue bloaters are overweight. Remember that chronic bronchitis is your blue bloater. Emphysema, that's your pink puffers, thin, barrel-chested, non-productive cough. That's pretty much baggy lungs. Emphysema is pretty much baggy lungs. They can't really squeeze all the air out of them anymore. Got a kind of a pinkish complexion, extreme dyspnea on exertion, prolonged inspiration. They got pursed lip breathing, and they got clubbing of the fingers. Clubbing of the fingers actually just means they have chronic hypoxia. It's a sign of chronic hypoxia. Now, that pursed lip breathing is actually putting back pressure back into their lungs. As they purse their lips, they're pushing air pressure backwards back towards their lung to try and force and keep alveoli out. There's a kind of a for you visual learners. Here is a picture of a chronic bronchitis patient. Oh, he's already still smoking. And that's part of the problem here is that most of them don't make any big lifestyle changes. They still smoke and eat and drink all the time. You know, it sounds like my family, to be honest with you. A lot of them got COPD and all this other medical problems. They just keep smoking and drinking. My Uncle Jim's on like his 4th or 5th stint. He just keeps drinking beer and smoking cigarettes and chasing women every day. Well, I don't think he's chasing women anymore. I don't know, to be honest with you. I don't care. So, dusky color, the cyanotic. They got cardiac enlargement. What's going on? Usually have right-sided heart failure coming to them. Here's your pink puffers, skinny little people. They got that pursed lip breathing here, that barrel chest. This is again for you visual learners there. What about a pulmonary embolism? All right, so pretty much a clot that has lodged itself in the lungs. We run a lot of these at the airport in Atlanta. You know, Nemaw gonna take this long 12-hour flight, not get up for 12 hours. She has clots in her legs, you know, DVT. She stands up and throws that bad boy, and it runs all the way out up to her lungs and gets stuck. So rapid onset of difficulty breathing and chest pain. Keep a high suspicion of patients without cardiac history. So things that can happen with patients. It's very common for patients that are bedridden chronically or after surgery to get a PE. Why? Well, if you are not moving, what does blood do when it doesn't move? It coagulates, it congeals, it forms clots. So anytime you are not moving for long periods of time, it's very possible for these things to form in your body. So bedridden, chronically or after surgery, long flights like from Meemaw taking her 12-hour ride, history of a DVT, they got DVT history, or being a female patient between teens and 40s on birth control. Taking birth control increases your ability and blood clotting, your blood's ability to clot. History, actually, in fact, this was a very big topic when I was in paramedic school like 13 years ago. It was a scenario that we had. It was like this 25-year-old girl is having, you know, chest pain. She can't breathe. She's very, you know, got dyspnea, O2 sats are dropping and blah, blah, blah. She's also got a history of smoking and takes birth control. There's nothing else wrong with her. And of course, if you smoke and take birth control, you're asking for a PE. So rapid onset of dyspnea or difficulty breathing, they have a cough, anxiety, blood pressure will shoot up, tachypnea. Best thing you can do is, of course, identify and rapidly transport. This is a surgical problem. This is something a physician needs to go in there and handle. You know, it's not something you can deal with. You can't pull clots out of lungs, so get them to a hospital sooner than later. All right, what about asthma? All right, so asthma is a two-pronged issue. We got bronchoconstriction and inflammation, but also don't forget mucus production. I'd say it's a three-pronged issue. So asthma is caused by bronchoconstriction and inflammation. They'll have dyspnea, intercostal muscle retractions, decreased LOC, trouble speaking, heart rate will increase, they'll have extra carbon dioxide going on. So they'll have elevated CO2 levels. So they're having an asthma attack. The main thing is you'll hear wheezing in the lower airway and they'll have difficulty breathing. Treat your patients, guys. I remember working with people before and like we pull up and I can hear them wheezing across the room before I even get to them. My partner is still trying to ask all these damn questions. And I'm like, dude, let's treat his problem, his breathing problem. We can get to the who's who later. This guy can barely speak. It's taking more effort for him to talk than it would for us to treat him. Let's stabilize him a little bit. So don't let your habits or dogma or finishing your report get in the way of you treating your patients or just trying to, getting a history is a great thing and we want to get a history, but if there's a glaring problem right in front of me, I would want you to treat the glaring problem first. Get a history, get his name and birthday later. So asthma, it's a disease that can be triggered. We get a lot of asthma attacks in the wintertime in the Atlanta area, a lot of them. Next, we got status asthmaticus. Status asthmaticus is when you have severe prolonged asthma attacks that has not been stopped by bronchodilators. All right, pneumonia and CHF, let's take them apart. Pneumonia can be viral or bacterial. The patient will have a fever with dry skin, green or yellow sputum, unilateral breath sound issues, which means one side of the lung sounds nice and normal. The other side will have some breath sound issues like rales, diminished breath sounds, absent, crackles. What has happened is there is an infection or a virus or a bacteria that has taken over a portion of their lung and it's not allowing for gas exchange, or if it is, it's very poor. And you can tell the lung is infected because they'll have that fever, the chills, possible weakness, and they'll be coughing up lung butter that's green or yellow or brown. I've seen brown lung butter and they had pneumonia. This patient needs antibiotics. If it's bacterial, they need to be transported to a hospital, manage their symptoms, airway, breathing, circulation, just provide supportive care at this point. Now, what about congestive heart failure, CHF? Hypertension and left ventricular failure is the #1 cause of this, and myocardial infarction can cause it because remember, dead meat don't beat. So if they've had a left-sided MI where that left ventricle has been affected, it's not going to create electricity. It's not going to conduct electricity. It's not excitable anymore, and it doesn't contract anymore. Dead meat don't beat. So it is useless and floppy over there. So they won't have a fever. They will be pale, diaphoretic, have moist skin. The blood pressure could be high, bilateral breath sounds issue, and they'd have dependent edema. Dependent edema is fluid collection that increases. It's usually in their arms and legs and lower extremities, but it is usually a sign of a heart failure patient. So how do we treat CHF? I've treated a lot of patients that have CHF exacerbation by sitting them up high in a high Fowler's position, almost at like a 90-degree angle, and giving them O2 via the nasal cannula. You don't always have to shoot big guns. But if they're having a lot of trouble breathing, O2 sats are continuously dropping, you hear all this wet, nasty lung sounds, you've got Cpap as an option as long as their blood pressure is high enough to tolerate it, as long as they have a normal mental status. They cannot be altered and they can have a low blood pressure. Pneumothorax. So pneumo meaning air, thorax, chest. So there's air trapped in the chest. So a simple pneumothorax, presence of air in the pleural space. You have a visceral and parietal pleura. As you breathe in and out, these pleurals will, touch and sometimes rub, but they usually can reduce friction by having, a fluid, some type of fluid to, decrease that friction or resistance. But there is a pleural space between the lungs and the chest wall. So if there's air trapped in there, that's a pneumothorax. So can be caused spontaneously or by trauma. You can pop a lung and air will be trapped in there. Breath sounds may be diminished or absent. Patient may be becoming dyspneic and restless and having increasing difficulty breathing. Now, what about a tension pneumothorax? Tension pneumothorax. So there's tension caused by the air trapped in the chest. And basically what's happened, this is a form of obstructive shock. It will have air trapped in the patient's chest, and it will start to push on the heart and great vessels, causing the heart to be put under tension, decreasing the amount of output the heart can produce. So next, the patient will exhibit JVD, or jugular venous distension. Jugular venous distension. What means is that their EJs here will be popping up, jumping way out, looking, hey, something going on here. Hyperresonance on percussion. I've never heard that in real life. I've had patients with tension pneumos and blah, 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 but I've never been able to percuss and hear a darn thing. But that is a nice registry word that I would say definitely is something you should know for that. Definitely know for that. But maybe you can percuss it. Maybe you're better at it than I am. But hyperresonance is definitely a registry word, or a registry buzzword. So make sure you know your buzzwords there. Subcutaneous emphysema, or Rice Krispies, and patients will become hypotensive in late stages of that obstructive shock. All right, so pneumo, hemo, and hemopneumothorax. Remember, a pneumothorax is what? Air trapped in the pleural space. Hemothorax, blood, chest. There's literally blood trapped in the chest here, and that, of course, will compress the lung, decrease diffusion and lung capacity. That patient actually just needs a chest tube. You can't do it in the field, so you need to get into an ER. Then you got a hemopneumothorax where there's blood and air. There's no need to pick. Another differentiation between a hemopneumothorax and a hemothorax is when you percuss the tension pneumothorax, you'll of course have hyperresonance. When you percuss the hemothorax, you'll hear a dull sound like slapping a watermelon. You can definitely hear the fluid in there. So like slapping a watermelon. Here's you a slide on how to differentiate between the two. Of course, the hemothorax could be a very hypovolemic issue, because you can hold up to, especially a massive hemothorax, that lung over there, that chest over there can hold 2,000 to 3,000 milliliters of blood. That's half your blood volume. Dullness on percussion, of course, narrowing pulse pressures, hypotension, hypovolume. There's no JVD. If anything, there are flat neck veins with a hemothorax. There are flat neck veins. So what about tension pneumo? That's accumulation of air. Your patient will have JVD, hyperresonance on percussion, subcutaneous emphysema. Patient will become hypotensive in late stages. Here's another diagram to help you visual learners figure that out. So what about the average BVM? I stole this from Foam Frat. I think it's called Foam Frat. Anyway, they're an EMS, Foam Frat. They're an EMS education site. I recommend you check them out. They're actually pretty cool. Got a lot of good information, good continuing education credits, stuff like that. So the average bag valve mass volumes, again, the adult mass can jump out, throw 1,600 mLs in there. A child's can throw out 500 mLs, and the infant can squirt 240 at you. So some predictors for difficult BVM ventilation: beards, me; obesity, me; older patients, Larry Vandergriff; toothless. Okay, you got me there. I don't know about this toothless. My uncle Joey. Yeah, he's toothless. Snores or stridor. If any of these or some of these are in place of you and treating your patient, you're about to bag them, you will know that they are predicting a difficult airway to manage with your BVM. So we already talked about OPAs. Here's just some more information on there. I could probably actually, when I go back and review these, this lecture, I can actually probably take this out. There's your MPAs. Again, I made these. So oxygen. Not all patients need high concentrations of oxygen. High doses of oxygen can actually be detrimental to patients with certain diseases like COPD. What does that mean? Well, it will affect their hypoxic drive. So what does that mean? They're not They're only stimulated to breathe when their oxygen sat falls to a certain level. So give them too much oxygen, you'll confuse the body. It'll stop breathing. They'll also get very altered because they're now becoming hypoxic. They will slow down their breathing. I've never had one stop breathing altogether, but they will become altered because they're hypoxic. They're not getting enough oxygen, not breathing enough air in and out. So anything above 94%, good stuff. Too much oxygen can also be dangerous for many reasons. Of course, there's absorption atelectasis, where you're pretty much drying out the lower airways and they start to stick together and the alveoli collapses. That's what atelectasis means, collapsed alveoli. And then, of course, you have all those free-floating oxygen molecules that are, of course, free radicals that'll run around and bash into cell walls, causing leaking and other changes there. So what can the EMTB do for oxygen delivery? You've got non-rebreather mask, of course. We've already covered that, so I'm going to keep on moving. So we didn't cover Cpap very much. So let's talk about it. Cpap stands for continuous positive airway pressure. This is about the biggest gun you can shoot without actually bagging the patient. You can see that it straps on a patient's head very tightly. It is actually very tight, and it is sealed on their face. And again, the better seal you got, the more effective it is. Again, someone like me with a big glorious beard, it would not seal on me very well. So it's non-invasive for ventilator support. It is very effective in the pre-hospital for treating COPD, pulmonary edema, acute bronchospasm. Patients must have a blood pressure over 100. Systolic top number must be over 100 because positive pressure will reduce the blood returning to the right side of the heart. It will affect their preload. So you cannot have a patient with a low blood pressure put on CPAP. They also must be able to tolerate it and not have altered mental status. You can't give this to a patient with altered mental status. Secondly, that whole they got to tolerate it thing it's true because CPAP feels very invasive. It feels like your lungs are stretched and they're about to pop, and they are possibly. So follow your local protocol, but this is very useful for the wet lung patients. Suctioning. So as the EMTB, you can only use the rigid suctioning, the hard tip Yonker or Harry Potter wand. And the big takeaway from this is that suction needs to be set to -80 to -120 for adults, and that you only suction on the way out. Only suction on the way out, and only do it for, you know what? I'm going to leave it there, but I can tell you that I learned over this last weekend that the reason that paramedics and EMTs have always taught you guys to suction on the way out is because when they wrote the original EMT and paramedic curriculum for suctioning, they asked a dental guy to do it. And in the dentist office, you only suction on the way out. It will not hurt your patient to suction on the way in. I learned that this last weekend. I thought it was hilarious that we had stuck to that dogma only because nobody had dared question why they had never wanted to change it. So it doesn't hurt the patient. Now, the time of suctioning will affect your patient. Don't get me wrong on that. But you can suction in or out. I found out this weekend at a conference that was complete horse manure. So adults, 15 seconds max. Don't gag them. Children, 10 seconds max. And infants, 5 seconds max. All right. So this guy over here, this white suctioning thing, it sucks, but not in a good way, because it's terrible machined. It doesn't work. It's all for the show. It doesn't really pull anything out of that airway. The best thing for you is this fixed wall unit in the back of the ambulance. That thing will suck the chrome off a trailer hitch. It's a bad boy. And this guy right here, I think it's that one from Laerdal. It's actually not too terrible, but it's not great either. It's not the best, but it does work better than, let's say, nothing. So again, make sure you have those non-rigid plastic catheters. Of course, you've got the Harry Potter wand, non-breakable disposable collection bladder or your suction canister, and water or sterile water for dipping between suctions. You want to clean that thing before you put it back in that airway. Quick review of BLS medications for the respiratory system. We got beta-2 agonist / bronchodilator, the Albuterol. This is a medication that will bronchodilate the lungs, and it's great for asthma, COPD, or anybody that's wheezing. If you wheezy, this is the guy to shoot at them. However, it is a beta agonist, and while we give it for beta 2 agonist purposes, which is we give it for lung issues, it will affect beta 1 as well, so it will increase heart rate. So they'll feel jittery and they'll feel kind of hyped up afterwards. And be careful giving it to patients that are tachycardic already. You don't want to make their tachycardia go higher. At that point, you kind of got to decide, do I want them to breathe or I want their heart rate to jump up? Kind of hard to decide there, but I would say if they got a pulse, it's ABC, right? So just use your best judgment there. A lot of services carry another option that does not elevate the heart rate, like let's say ipratropium bromide or Atrovent. Atrovent is a great bronchodilator. It's a great drug, and it doesn't affect the heart rate. It's great for patients that, like, let's say congestive heart failure, you know, or somebody that does not need their heart rate jumped up. Because if you increase heart rate, you increase oxygen demand for more blood flow, more oxygen, and then you may not can give it to them. Of course, oxygen is a drug. Oxygen is a medication. It is a drug, a gas, and element. Target 94 to 99%. Everybody gets something. Never withhold oxygen. Matter of fact, for your registry purposes, put everybody on oxygen. 1 to 15 liters, depending on the device. Entitled CO2. I include this into the EMTB curriculum just because I want to be thorough, but it's measuring the maximum amount of CO2 at the end of an exhaled breath. So when they breathe out, it's measuring what their CO2 output is. If they have low CO2 levels, they are hyperventilating, they got decreased CO2, return to the lungs, and decreased CO2 production at the cellular level. Remember, CO2 is a byproduct of cellular metabolism. If there's not CO2 being produced, then cells are not going through their cellular respiration. High CO2 levels means that they have ventilatory inadequacy. They're not breathing enough off, or they're apneic. Keep that in mind. Measured using capnometry or a capnography device. Normal range is 35 to 45. Can be used in spontaneously breathing patients with a special CO2 reading nasal cannula. Always encourage your medics to use capnography for their intubation purposes. It is the gold standard for verification that a tube is in the right spot. It's also the gold standard for targeted ventilatory assistance with a either apneic or a patient in arrest or post-ROSC patient. So that is something you need to push on your paramedics there. And that is our airway section, National Registry Prep. Again, big thing is know your terminology, medical terminology, understanding and comprehending what they're actually asking you, and also make sure you know your adjuncts and when and where to shoot each one at each patient you're given. So that's all I got for you tonight, guys. Y'all have a blessed evening. Good luck with your National Registry. We're going to keep on keeping on and finishing out this National Registry prep. I hope you're getting a lot out of it. If you got any kind of comments, concerns, or things you think I should add to the prep, please let me know. It is a work in progress. I wrote some of this. Somebody else sent me some good slides for it. I had some slides from something I've done before. I'm just trying to build a National Registry doomsday weapon to give registry, you know, a nice big, hey, sorry, but these guys are getting their license. We need them, and we need them to have it now. So good luck with all that. Y'all email me, text me, whatever you want, and tell me what it needs. But again, this is not comprehensive. There's no way I could cover everything that the airway and ventilatory management of a patient is in its in an entirety. So it's a good start, though. Good start. All right, y'all be easy.